Welcome to the JACC Edge podcast. This is your host, Pratik Doshi. I currently serve as the editor of JACC Edge, a monthly newsletter where we do a deep dive review of hot topics in cardiology in an innovative format. I'm really happy to be joined today with Dr. Roswell and Dr. Solomon, both of whom are experts in critical care cardiology. Dr. Robert Roswell is the Associate Dean for Diversity, Equity, and Inclusion and Professor of Cardiology and Science Education at the Zucker School of Medicine at Hofstra/Northwell. He serves as an officer to the Board of Directors of the American Board of Internal Medicine and is currently a member of ACC's Board of Trustees Health Equity Task Force. He additionally is the inaugural co-chair of the Critical Care Cardiology member section of the ACC and the co-director of the Cardiac Intensive Care Unit at Lenox Hill Hospital in Northwell in New York City. Dr. Michael Solomon is a senior research physician at the NIH with a dual appointment in the Critical Care Medicine Department of the Clinical Center and the Cardiology branch of the NIH LBI. He's the vice chair of the NIH Staff Clinician Council and the co-director of the NIH Pulmonary Hypertension Translational Research Section. He also serves as the inaugural co-chair of the Critical Care Cardiology Member Section Leadership Council of the ACC and also chairs the ACC Credentialing and Membership Services Committee. Thank you both for being here. I'm very, very excited to speak with you today. Before we start, I'd like to have both of you give a one-liner about yourself. Dr. Roswell, can you please give us a one-liner about who you are and what you enjoy outside of medicine?
Sure. So I'm an Associate Dean for Diversity, Equity, and Inclusion and the co-director of the Cardiac ICU at Lenox Hill, Northwell Health in New York. And I think one thing I love to do outside of medicine is travel. And so I'm particularly excited as things have reopened to travel all over the world because I love traveling, experiencing different cultures and foods.
Any particular travel location come to mind or any travel plans coming up?
That's a good question. I think I am traveling a lot for work, but I do have some travel to the Caribbean, and I really love traveling to Europe, South America, and the Caribbean. And I recently got back from Trinidad because there's a carnival celebration there, and my family's from the Caribbean, so it was great going to Trinidad and also stopped in Guyana, where my mother is from, in South America on the way back.
For anyone who's traveling, Dr. Roswell might be a good person to reach out to. Dr. Solomon, one-liner about yourself.
Sure. I'm Mike Solomon, and I'm a critical care cardiologist at the National Institutes of Health. I guess for me, outside of work, I always like things that are kind of a little bit on the opposite ends of the spectrum. I used to love looking in microscopes and telescopes. And so for me, where I live one direction, I can go see all the nice museums on the mall. And if I go in a different direction, I'm out hiking in the Shenandoahs.
That's amazing. Yeah. I was in Durham and Duke for med school and love spending time outdoors. It's a beautiful spot and would drive up to DC all the time. So I'm glad you can enjoy both ends of it.
It's great.
Yeah. So to jump into our topic for today, critical care cardiology. It seems like you guys are having a big blossoming moment where there's so much attention, there's so much energy, and both from the resident perspective and the fellow perspective, as well as I'm sure the early career and later career perspective, everyone is really excited about this becoming, coming into its own essentially. Can you speak a little bit about what led you both to enter this field and assume the positions that you currently hold?
Yeah, I think many of us probably have similar stories where in cardiology fellowship, and I think even before starting cardiology, it's like the pathophysiology that would attract you to a specific field. And that's what happened with cardiology. And while I was in cardiology, it was in my cardiac ICU rotation that I felt the most sort of aligned, and I enjoyed the patients and the acuity of care. And when I looked around at those who were running the cardiac ICU, I asked, how did you become involved in this? Mm-hmm. How do you become a director? And they all shrugged their shoulders and said, just do this. And I always knew that was something I wanted to do. And I think many of us who work in cardiac ICUs really balanced at some point in our training, did we want to do pulmonary critical care? Do we want to do cardiology at the sort of the outskirts of cardiac ICU? Because it wasn't really a developed field, and we all struggled with pulmonary critical care or cardiology, and then we saw that there was cardiac ICU, and so I think we all had those thoughts going around. And I probably wouldn't be here if pulmonary critical care involved the lungs, and I could not focus on asthma and COPD and all those other really important pulmonary diseases. And that was a game changer for me, where I knew I didn't belong in pulmonary critical care. I would go to cardiology, and then luckily fell in love with the cardiac ICU.
Well, I think I speak for everyone when we're very fortunate to have you, on the cardiology spectrum of things. Dr. Solomon, what about your journey?
Yeah, no, my story's a little similar. The journey's a little different. I was doing my internship and residency, and I felt most comfortable in the intensive care units. I had gone and worked in the pulmonary intensive care unit, the MICU, as well as the cardiac intensive care unit. And I really couldn't make a decision. Should I do pulmonary or cardiology? I didn't really have enough information at that stage in my career. And at that point, there was this new fellowship I had heard of, and it was called Critical Care Medicine. And they had a program at the National Institutes of Health, and they were taking people who were interested in cardiology, pulmonary, and all these other specialties. And so I said, well, I need some more time. And so I went and did it, and I got to experience a very big breath of what it felt like to be in an ICU. I mean, I got to do bronchoscopy, and I also got to do right heart catheterizations, and it came down to bronchoscope, looking at mucus. That wasn't my deal, but doing catheterization, that I liked, and so off I went to after critical care to a cardiology program. And because I had critical care skills at that point, heart failure transplant was kind of getting off the ground, and I decided that they were using immunosuppressives in their patients, and I had that skill from critical care, and so I moved into heart failure transplant for a few years, and then gravitated back to the cardiac ICU.
That's awesome. Well, again, we're very excited to have you, and I think both of you bring a wealth of experience and have really shaped the field into what it is today. And I think that brings me to my next question. Where does critical care cardiology stand currently, and where do you see it going in the future? Because I know there's been a lot of discussion about, is this an offshoot of advanced heart failure, or does it stand alone? So where do you see this as its own entity?
Well, I think this is something that we both agree on, is that it stands alone. I think it depends on your particular cardiac ICU, what you'll see. If you're a quaternary center that does a lot of transplant for cardiogenic shock, you may see a lot of heart failure related, cardiac ICU patients. Other cardiac ICUs, let's say, for example, one that I work in, we see a lot of cardiac arrest, we see VT storm, we see a lot of bad endocarditis that gives you shock, we see a lot of mixed shock, and so you get to see that there's different flavors of cardiac ICUs, which makes it difficult, because if there's one that's all cardiogenic shock, one that's seeing cardiac arrest and arrhythmias, and then you're seeing SVTs mixed with medical comorbidities, that's what makes it so interesting, because if you're at one center versus another, you have a different perspective of what you think cardiac ICU physicians should be, what the cardiac ICUs are like. And this is why I think the member section is important, because we need a comprehensive national or even global perspective of what critical care cardiology is. And we can't sort of focus on particular centers that do a particular specialty, whether it's transplant or something else, and have that define what cardiac critical care cardiology is. And so I think it's really important that it stands alone, and it covers a breadth of many different diseases and diagnoses. And I think, and from our section, just looking at that from a 30,000-foot view, we see that. So strongly think that it stands alone.
Yeah, absolutely.
Yeah, no, Rob and I talk about this a lot. We talk about it a lot in the council and within the section, and that's why we encourage people to join the council, join the section, participate in the new critical care cardiology section. I think the other thing that Rob and I realize is that there really is a shortage of critical care cardiologists, and there's a great need out there. And so, we also take a big tent approach. And so, the idea is, while we agree that there is a definitely stands alone, I think you have to look, and Rob and I have talked about this, at what the CICUs need, right? So not all CICUs are created equal. Just, there's level 1, level 2, level 3. You could take that from the trauma centers the same way. And there's these, as Rob mentioned, there's these level 1 CICUs that do it all, right? They do ECMO, they do LVADs, they have 24-hour service for cardiac catheterization and transplant and everything. And then there are other CICUs that have different roles, the level 2 and the level 3. And so the competencies to work in those different CICUs are different. And so with that in mind, you define the competencies for those different CICUs, and then you say, okay, what type of training do you need to work in those CICUs? So, there are people in heart failure and there are people in interventional and other specialties that do have overlap with critical care cardiology, but there's still a skill set that someone who does straight critical care cardiology has that is not part of heart failure transplant or interventional. And so if a heart failure transplant person wants to be a critical care cardiologist, we agree that no one, they should be allowed to practice, but they're going to have to gain a certain skill set based on the level of CICU they want to work in, whether it's a level 3, a level 2, or a level 1. So we're used to competencies, right? We in training programs, we have level 1, level 2, level 3 competencies. In this case, level 3 is the highest. So if someone attains a level 3 competency in critical care, those are usually, again, individuals who have done a year of critical care, and they're the person that's going to be working in a level 1 CICU. But there's also ways to obtain competencies in level 1 and level 2 critical care. And while those might not allow you to sit for a board certification the same as a level 3, maybe it will allow you to get a certificate from your training program, or you could get it by practicing from a society, and then you could function in other level CICUs, but you still got to get the skill sets, right? Because the bottom line is the patient, right? The patient we're caring for. We have to have the competencies to care for those patients in those CICUs. So it can be a big tent approach, but I do agree with Rob. There is definitely a place for people who want to do critical care cardiology as a subspecialty outside of the other subspecialties.
Absolutely. So then do you see the field then shifting towards creating more fellowship or sub-fellowship programs and kind of expanding that way? Or are there opportunities at the practice level where you're an early career attending or a mid-career attending who wants to shift their focus a little bit more to focus on critical care patients? How does one kind of navigate working in such a diverse playing field?
So I'll let Rob start, because he also, as you mentioned, works with the ABIM and has thought about this a lot, and I'll give some comments too. But
yeah, I think it's complicated yet simple, because at the end of it, it's always patients and patient care. And I think what we're thinking about is that you definitely need training and a training pathway, and it's difficult. So we're trying to figure that out right now, because we have to figure out the competencies before you figure out exactly what the correct training pathway is. So right now, there are cardiac critical care fellowship programs. There are standalone critical care medicine programs, both which would suffice to sit for ABIM boards for you to be certified in critical care medicine. And then there are other people who have been doing critical care cardiology for the past 20 years, and they have kept up. They know about respiratory failure and mechanical ventilation, renal failure, and all those things. And so I think this is an important point for what our section is doing, is really putting together the competencies and figuring out how we normalize standard of care to a high quality, where if you're practicing in a level 2 or even maybe a level 1 cardiac ICU, we want to make sure that you have certain competencies and you meet a certain standard for that patient population. And for those coming now along the pike, you have to make sure that you also have that training to practice in a level 1 CICU if that's your desire. But I think it's difficult, because it's moving a lot of parts and making sure people really have the competencies. And I think, let's say for heart failure interventional, they all have some competencies that a critical care cardiologist has, but may not have all. And especially when it comes to respiratory failure, mechanical ventilation, advanced mechanical ventilation, those are some of the main competencies that they particularly lack.
Yeah, so I think I was maybe a PGY 9 before I was able to get my first job, and again, that's a very long time to train. And so I think the aspirational model would be to have these integrated critical care medicine competencies within a cardiology fellowship, so that you could do your general cardiology in the same way you choose to do heart failure transplant or interventional. your program director would also have a path if you wanted to do critical care cardiology. And then if your heart failure transplant, as we mentioned before, interventional, then they would be able to understand, okay, if I know what the competencies are for someone who wants to do straight critical care cardiology, then I can figure out what competencies are needed if a heart failure or an interventional or even an EP person wants to do critical care cardiology, which ones do they already have and which ones do they need to get. But I think it really starts with the patient and the CICU, right? We need to decide what are the competencies that are needed to practice in the various CICUs, and then we need to go ahead and translate that into the training programs. And then there has to be a whole pathway where there has to be conversations with ACGME and ABIM and get everyone on the same page. And so it's a process. I think we've taken the first steps down this path, and hopefully we have a map, and we're just gonna have to keep walking it.
Yeah, I think what's really commendable is the fact that this is all patient-driven. From again the resident and fellow perspective, you're used to what you see at your institution, but you often don't have that perspective that there's different types of CICUs essentially depending on the location and practice setting. So while there's critical care components probably built into most fellowship programs and probably most of what cardiologists who are working in these types of settings are doing, it may not be everything you would need to be a fully fledged cardiac critical or critical care doctor in that setting.
And then there are staffing models, right? So, getting back to what we discussed, if you're at that highest CICU level, you probably need a full-time critical care cardiologist, to be the conductor in your CICU, someone to be standing there at the bedside making decisions. But as you go down in CICU levels, right, 2 and 3, you could think of other staffing models, right? Do you have a cardiologist who is working in conjunction with someone who's just done critical care medicine? Or, in some level, do you have someone who's either there as a consultant or full-time? So it's different. The staffing models are going to be different depending upon not just the competencies, but the staffing models will be different depending upon the CICU. So again, it all starts with who are the patients that need to be cared for and what level of competencies and what level of staffing do they need.
Yeah.
I think, for example, if you take a patient, for example, and look at their course from somebody, let's say, coming into cardiogenic shock, which is what we talk a lot about, and look at that patient coming in the emergency room, and they developed respiratory failure, and they're going to the cath lab. Let's even say this is AMI, cardiogenic shock. I've been that person who accompanies that patient in the cath lab while they're getting their intervention, looking at their respiratory dynamics. Do they need to be intubated at this point? And if they are, what are the vent settings that we're putting the patient on? What drips should we start the patient on? And I actually love being in the cath lab as a critical care cardiologist, because sometimes you get those patients from the cath lab, but it's so great to be a part of the care of that patient, to sort of have evidence-based guidelines that you should start this drip, let's do this, let's start this patient on these vent settings because this is how this patient should be vented given that they're in cardiogenic shock right now. And then having heart failure as part of that team is very helpful as well. But you see how Mike is talking about being the conductor. We're really at the nexus of all of these different subspecialists, and whether it's electrical storm with EP, cardiogenic shock, heart failure interventional, and other services, we're really the ones that are sort of managing and putting everybody together, like the conductor that you mentioned.
Yeah.
I like that analogy.
Yeah, no, that's an excellent, I think that's a perfect prototypical example, because we've all had the STEMI or AMI patient, and we're trying to make sure that the patient doesn't have a code event during their cath, and having somebody that understands kind of both the dynamics on the rest, outside of just the cardiac system, I think is an important part of patient care. And again, depending on the setting and the type of patient that usually walks in the door. So, yeah.
And one last thing, and I will credit Jason Katz for saying this, and I 100% agree that critical care cardiology is not a subspecialty of cardiology. It's a super specialty, because we don't focus on a narrow part of cardiology. We actually expand into other parts of cardiology and actually other parts of internal medicine and critical care medicine. And
Absolutely.
So going to credit him for that, but I think it is a fitting term.
Definitely.
Credit him for a lot of things.
Yes.
So to shift gears just a little bit, I know both of you have very illustrious research careers and have spent a lot of time thinking about critical care medicine within cardiology. What are the research gaps that you guys are looking at currently that we need to fill in order to better serve this field?
I think one of a lot of the research that comes out in critical care cardiology, right, is retrospective.
Mm-hmm.
And it's hard to do a prospective trial in a critical care environment, and that's something that's being worked on. And again, if you want to credit someone else, I would credit Dave Murrow with Critical Care Cardiology Trials Network in really trying to fill the research gaps in critical care cardiology. They've done a wonderful job of recruiting level 1 CICUs throughout the US. There are over 30, I believe, now. And they've published numerous papers really very descriptive on what the care looks like currently in the CICU, but we have to take the next step, and that's being able to do things prospectively.
Yeah, I agree, and I credit Dave as well. I think there's a couple of things that I think overall we're realizing about cardiogenic shock, since we're talking about that, and how heterogeneous it is. And so figuring out how we get phenotypes of cardiogenic shock, because the more you study it, the more you realize that there's so many different types, and it's hard to sort of say what's good for cardiogenic shock itself because it's so heterogeneous. And I think with everything that we're studying in cardiology, we always should be, and I think this is what we're doing now, studying everything through a lens of health equity and looking at disparities, whether it's by bystander CPR, cardiac arrest, being offered advanced procedures. I think that's another lens through which that we're looking at research and the delivery of equitable healthcare, which is something our section is trying to look at as well. And I think that is a great sort of future for research generally in cardiovascular care, but something that we've been looking at as well.
I think what's really cool is both of you have the opportunity to essentially set the tone for the field where diversity, equity, and inclusion are critical components, not only within training programs and fellowship programs or whatever that may look like, but in addition, the research component and essentially being able to, I think it's rare to have the opportunity to really develop a field in that way. And speaking to some of your work that you've done on the health equity front.
Yeah, and I think it's great for critical care cardiology, and it's great for cardiovascular medicine in general. I think we have taken this time to really look forward and say, what would critical care cardiology look like? We've done the Women in Critical Care Cardiology webinar, and we're looking at cardiology in general and looking at the low number of female cardiologists, and we said that can't happen in this particular super specialty, if I can call it that now. And so looking at ways to make sure that critical care cardiology is inclusive and diverse as possible. And so I always think it's a great opportunity to shape the field, and having a great leadership council, having great support from the college, and a great co-chair, it really advances the mission.
Absolutely.
Yeah, and even at the ACC Scientific Sessions 23, we actually created a Women in Critical Care Cardiology work group because we're really serious about being more inclusive, and we need to get there, and that's important. And I think the other thing I would say is that I think all that we've accomplished, I don't think either of us could have done it by ourselves. I think having inaugural co-chairs was great, and working with Rob has been one of the best parts of being part of the Critical Care Cardiology Council.
Absolutely. You all seem like you have a great working relationship and a great friendship. So it's amazing to have the opportunity to have this discussion with you. And I thank both of you, Dr. Roswell, Dr. Solomon, for your time and your insights into what critical care medicine and cardiology will look like. Any resources or things you would like to share for people who are interested in learning more?
I'd have, I guess, one comment I just want to make. I think one of the barriers initially for critical care cardiology was terminology. People were using the terms open and closed CICU. No one wants to close a CICU in the terms of saying the general cardiologist, stops at the door. That's not what we're about. We're about collaboratively managing patients. The general cardiologist is still extremely important because they've been following this patient their whole life, right? In and out of the hospitals, in and out of clinics. And like Rob and I were saying, we see us as the conductor, right? And so everyone has a part. We still need the interventionists, we still need the heart failure doctors, we still need the EP expertise, and we still need the general cardiologists. But we hope that they'll sleep better at night knowing that there's someone standing there in their CICU when they have to go to the cath lab or the EP lab or be in a heart failure clinic or do rounds at 2 or 3 different or more hospitals. There's someone in that CICU that has listened to them and is there watching their patient and trying to help their patient get better.
And I 100% agree. And I think for critical care cardiology, I'm very proud of the fact that we are having a lot of collaboration. For example, with the Society of Critical Care Medicine, with chest physicians and that particular society. We're having collaborations with our cousins across the pond and the ACVC, the Acute Cardiovascular Care Committee, part of ESC. And so what I feel is this great collaboration that's forming that's also adding to the momentum of people knowing about critical care cardiology and really advancing outcomes in this very sick patient population.
Yeah, I will say from the resident perspective, it is really nice to see faculty members such as yourselves come together in such a way and create these options and really push the field forward. So I'm really excited for what's to come for both myself and for all of you as well. Again, I want to say thank you for your time and your insights. For our listeners, thank you for listening to the JACC Edge podcast. If you want to learn more about critical care medicine, please follow us on the JACC Edge newsletter and Dr. Roswell and Dr. Solomon on their social media, which we'll link in our show notes. Anything else that you would like to add before we wrap up?
Become a critical care cardiologist. Join our member section.
Keep the momentum going.
Right.
Absolutely. Thank you both again.
Thank you.